Thank you. Good morning. Bladen Healthcare and Hoke Healthcare are two rural hospitals with associated clinics in the 8-hospital system of Cape Fear Valley Health. Bladen is a 25-bed critical access hospital with about 13,000 emergency department visits per year and about 600 admissions per year. It's seated in Elizabethtown, North Carolina, and it serves an aging population of about 34,000. Hoke Hospital is a 41-bed rural acute care facility that opened 5 years ago in Rayford, North Carolina. There are 40,000 ED visits per year and about 1,600 admissions. Hoke County has a population of about 50,000 citizens and is located adjacent to Fort Bragg. Both facilities are full service with the exception of obstetrics, although both have obstetric practices with deliveries occurring at the flagship hospital. Because of work-life balance needs, particularly in rural areas, many physicians prefer either outpatient or inpatient medicine. Thus, the inpatient care models at Bladen and Hoke use hospitalists to care for admitted patients. The models differed somewhat. Bladen provided in-house hospitalist coverage 24/7, 365 days per year, with 2 consistent MDs for days, but the nights were covered in a piecemeal fashion with many per diem providers. At Hope, the coverage was in-house until 11 p.m. and then as needed. Opening just 5 years ago, the facility did not experience the current volume it has today. The 2 full-time hospitalists covered the day and evening shifts as they were rarely contacted for admissions or by the staff for orders. They received compensation for the additional hours. As volumes grew in the ED, so did the medical unit census and the number of calls received by the hospitalist. As we got busier, we needed a different model. However, it could not mirror the model of Bladen. The solution? After researching various models, I settled on a telehospitalist model and vetted several companies that could provide night or nocturnal coverage. As a physician, I had many questions and concerns. How would they care for critical care patients, i.e. codes and rapid responses? What about ICU patients? Could hospital patients be taken care of virtually? How would they examine the patient? Would patients, staffs, and providers embrace the technology? What about patient experience? Would nurses feel comfortable performing the hands-on parts of the exams? What would be the quality of care? I and my team chose to move forward with the model of telehospitalists providing inpatient acute care at night. We vetted each company thoroughly and decided on one. We worked in tandem with the company to devise a rollout that was tailored to our needs, not the canned rollout format. We prepared the staff, physicians, and community with demonstrations of how the new model would work. We actually demonstrated using the telehospitalist assigned to our facilities. We shared press releases to the local papers and invited reporters to see the new model. We reorganized and set expectations with regards to admit to floor times, admit decision to admit order times, and instituted policies to ensure consistent care. We provided a comprehensive rollout strategy to include mock codes, rapid responses, patient transfers, trial runs with the use of the technology. We ensured telehospitalists had access to health records for review and to use input orders and write notes. I have monthly conference calls to discuss any issues and to level set. I've not experienced any cons with the use of this model and will continue to use it and perhaps use it more broadly. Our results? We decreased costs to both facilities. We decreased costs at Bladen by about $300,000 per year and at Hope by about $250,000 per year. We increased patient experience as measured by Press Ganey surveys. We even measured the experience of our telehospitalists, and they received very high scores. The wait time in the emergency department for orders has decreased, and patients actually like the technology, both old and new. It's often referred to as the TV doc. The staff and other providers' experience has been positive. The staff feels more comfortable contacting providers at night. They use secure chat or telephone. We have more consistent provider teams. Staff they feel comfortable with the provider practice patterns. The ED providers and day hospitalists enjoy a relationship with a team of providers from other areas. Quality has been consistent as well. Because we have consistent providers, we've noticed improvements in our metrics, in our quality metrics. We also note that notes and documentation are more succinct and timely, and codes and rapid responses are handled well and efficiently. And our admissions have increased. Our ED providers are comfortable with handing off to consistent providers. We've used this technology since 2017, and each year our admissions have increased. Our patient satisfaction is extremely well, and I am satisfied with the care that's provided. This is what it looks like. This is our cart. The cart has stethoscope, otoscope, ophthalmoscope. You can actually hear and listen to the patient's hearts and lungs. They can see the provider can see them, they can interact easily. The nurse does the hands-on exam, so if, let's say, a patient has pneumonia and the doc wants to listen to the patient's lungs, the nurses were trained to place the stethoscope in appropriate areas on the patient's chest, the same with the heart as well, and it works extremely well. These are some of the metrics that I asked the company to provide for us from the beginning. The thing I want to point out here is secure messaging response time. When the nurses secure message the providers, the average time is 12 seconds in returning a message. These are, again, additional snapshots, and the rest of the slides are basically just the data that I collect from the company. Thank you.